Good day, everyone. Several of us have joined from different parts of the country, so I guess good day is in place. You're welcome to the Psycho-Oncology Society of Nigeria webinar. We're going to have an educative and insightful webinar today. This is the first webinar we're having this year in 2026, and we're hoping to have at least 3 more before the year comes to an end. And it promises to be a very insightful, educative webinar. We have distinguished speakers who will be talking to us today about the psychosocial screening for children and adolescent cancer patients and survivors, what every clinician needs to know. So it will be engaging as well. We'll also want to hear from you after we've listened to our guest speakers. So I would ask Ms. Blessing to please introduce our guest speaker for today. Ms. Blessing, please go ahead and introduce our distinguished guest speaker for today's webinar. Okay, I'll just go ahead and introduce her. So she's someone who is a distinguished person in the field of psycho-oncology. Most of us would definitely would have come across her. Her name is Dr. Elizabeth Akindoye. She's a clinical psychologist, psycho-oncologist at the University College Hospital, Ibadan. She's also the president of the Psycho-Oncology Society of Nigeria. She has distinguished herself in terms of research, clinical training, not just in Nigeria, but also in Africa. And she has a special specialty in pediatric psycho-oncology. And so we're listening to a seasoned person who's going to tell us what we need to know as clinicians and healthcare professionals when it comes to psychosocial screening for children and also adolescents. So please make welcome Dr. Elizabeth Akindoye. Thank you so much, ma'am. The floor is yours.
Thank you very much. Thank you very much, Dr. Sarimiye, for that warm introduction. Can you see my slide?
And yes, we can.
Great. So, like Dr. Sarimiye has said, I am Elizabeth Akindoye, and today I have the pleasure to be speaking on the psychosocial screening for children and adolescents, cancer patients, and survivors. And before I actually start, I'd like to appreciate the presence of Professor Chioma Asuzu, the IPOS president. It's an honor for us to have her in this gathering because I saw her name scroll through when she joined the room. Thank you so very much, Ma, for creating the time to join us this evening. Okay, so the objectives for this presentation are just simple: to define psychosocial screening in pediatric oncology, explain the rationale for the screening in pediatric oncology, identify psychosocial domains in pediatric oncology, present pediatric psychosocial oncology screening tools and strategies that we could use, and as well as discuss the implementation in clinical practice. Okay, in a way of introduction, the World Health Organization estimates that over 400,000 children are diagnosed with cancer every year. And in Nigeria, children make up about 7.2% of the 127,000 cancer cases that are seen annually. Over 85% of children in sub-Saharan Africa diagnosed of pediatric cancer are likely to lose their life yearly, primarily due to poor access, illiteracy, which also leads to late detection of the ailment, and then treatment abandonment, financial burden, as well as poor family support. And so children and adolescents with cancer, are a highly vulnerable people, along with those that take care of these children. Because from the point of diagnosis to the treatment to survivorship or end of life, there are always one form of distress or the other. And this underscores the need for psychosocial care for people affected by pediatric cancer. Okay, so the socio-ecological approach to child health is a holistic framework that analyzes how interconnected factors or interconnected variables, at the individual level, say the patient's level, the individual parents or siblings level, and the interpersonal level in terms of relationships at school, in the neighborhood, and all of that, at the community and society at large. All of these factors shape, first and foremost, the child's development and also the child's well-being. So it moves beyond just the individual, to focus intervention to address the broader environmental factors, including cultural norms, the policies that guide the healthcare of these children, and the physical environment in which they live. And we know that children on their own can really do nothing to help themselves. And there's this bi-directional relationship between the child and the family from which they come, and how they are able to cope with the disease and its aftermath, is highly interconnected. And so it's important to have a holistic view when addressing issues in pediatric oncology. And then in terms of the social determinants of health, which refers to the conditions in which people live, right? Their environment, where they live, they work, they access healthcare. This condition significantly also impacts pediatric oncology outcomes, especially in terms of lower socioeconomic status, the lack of insurance that is linked to high mortality, and as well as advanced stage of the disease at diagnosis. And of course, would also affect the long-term survival of these children. So addressing social determinants of health is critical, because factors such as where the individual lives, in terms of housing instability, transportation to the places where they will access care, having balanced diets, and all of these have implication for a child's health. So psychosocial screening is the first effort at identifying the psychological and social factors that can impact the initial response to diagnosis, ability to manage the demands of treatment, as well as the long-term outcomes for pediatric cancer patients and their families. Holistic care is the treatment of the total person, considering their needs across multiple psychosocial domains, such as the physical domains. Is this child experiencing pain? Are there sort of some form of physical deformation or disfigurement due to the disease itself, or as an aftermath of the disease treatment that could involve amputation of body parts? The experience of certain symptoms that are not properly controlled are areas that should be looked at, because when we look at the domains of human development, a negative impact in a particular aspect will cut across most of the other aspects. And so there's a need to address this. And then the emotional domain that has to do with anxiety and fear, say procedural anxiety that patients may experience, anticipatory fear for parents sometimes when children are experiencing this kind of issues that are worth paying attention to in pediatric oncology. There's also that area of the social domain that has to do with interpersonal relationship, peer relationship, because this child belongs to a school, a religious center in their neighborhood. There are children they also play with, and a disease like pediatric cancer could impact this relationship and how the child sees himself or herself vis-a-vis how others view them and are willing to relate with them. Under the social domain also, we may look at the family dynamics and the economic status, of this patient's family members, and because this also have great implication. Then cognitive domains in terms of attention, memory, learning difficulties, because most of these children, some of them are school-aged, usually the adolescents, early childhood, those at the early childhood stage of development. They are already, some are already in school. And so this also have implication for their scholastic or academic performance. And then I also think we also need to look at the behavioral component also, because sometimes children may start acting out because of the illness, because maybe poor communication, the side effects, they may engage in risky behaviors, they may stop adhering to treatments, they may have difficulty coping. And so part of these psychosocial domains and having an holistic view is being able to assess, screen for how this child is coping and dealing with this condition. So what is the rationale, or what are the rationales for psychosocial screening? Let's put it out there. I mean, if you've worked with children in pediatrics or their parents, you'll find out that many of them are quite resilient, right? But despite this, some still have concerns that are high enough to impact how they are able to manage the disease outcome and the disease process. And so the goal of screening is to identify those at greatest risk of psychosocial problems as early as possible, so that interventions can be provided to mitigate both the short and the long-term impact of those risk factors. I mean, the general idea is to even prevent those risk factors from manifesting, because if we never screen, then we are never able to find out. And then this preventative approach also increases the efficiency of workflow by placing attention and resources on where it is most needed. And that allows for equity. It allows for a reduction in health disparity when we are able to place resources, care, and attention for the fitting resources to the particular need of each individual. Also, when we screen for psychosocial functioning in pediatric oncology, we are aligning our practice with the standards in the National Pediatric Psychosocial Standards of Care and the recommendation of key professional societies, right? That psychosocial functioning should be assessed, psychosocial distress should be assessed as a sixth vital sign. Then psychosocial screening also fosters effective communication between the multidisciplinary healthcare team. So ordinarily, you may not have a psychologist treating a cancer patient, but when you have a multidisciplinary team, each one is able to bring their perspective, the perspective of their training, to bear in the care of these patients. It also fosters communication between the healthcare providers and the family. And this is very important to promote adherence to treatment and to help address the fears of the family members and of the patients that may make them abscond, from assessing or from continuing treatment. And so when we include psychosocial indicators, institutional, local, or national cancer registries, It could also help inform prevention and intervention policies and programs at various levels. What is not assessed seems not to exist, but once it is assessed, it is documented, then it is easy to use this data to allow us drive policies based on information. So there are several tools, right, for assessing, for screening in pediatric, for psychosocial oncology screening in pediatric cancer. And there are some tools, a few tools that are cancer specific, pediatric cancer specific. There are others that are generic, but some have been commonly used in cancer, in pediatric cancer. And so one of the most common tools is the psychosocial assessment tool, PAT. It's a standardized psychosocial risk screener, particularly used in pediatric oncology, and is based on the preventative health model, psychosocial preventative health model. It consists of 7 subscales, looking at family structure or resources, family problems, social support, to admit somebody. Okay, social support, family beliefs, the child-specific problems, and the sibling problems. And so this tool assesses all of this. This tool is freely available, but is based on request. There's also the pediatric quality of life inventory, the cancer module. There's also the generic form, but this one is specifically for pediatric cancer. It is also free for non-funded research. So it's just a matter of contacting the developers, and they will make it available. And so this pediatric quality of life inventory has 27 items. And the beauty of it is that it has different scales specific to different developmental level. And so there is that scale for even toddlers, 2 years to 4 years. This is purely parent reported. And then there are also those scales that have both the self-report and the parent proxy report for children 5 to 7 years, 8 to 12, 13 to 18. And there are even versions for adults. So it assesses problems related to pain and hurt, nausea, procedural anxiety, treatment anxiety, worry, cognitive problem, perceived physical appearance, and communication. And so we say that this quality of life inventory, the cancer module, covers a broad range of psychosocial concerns in pediatric oncology. We also have those other general psychosocial screeners, which I will not be describing in detail, but something that we could Google, and they are freely available online. But worthy of note is the pediatric distress thermometer rating scale and the distress thermometer for parents. The distress thermometer is one of the most common tools that is used in adult oncology. And its use is being extended to the pediatric context, with versions tailored to patients and another tailored to the parents. So it screens for distress on a visual analog scale that appears as a thermometer. So on a scale of 0 to 10, 1 to 10, the individual is able to cycle the level of distress that he or she is experiencing. And then there are other aspects where they could report where the problems really are in terms of the problem checklist, addressing emotional, physical, practical, social or family, spiritual concerns, and other problems. I would encourage you to just seek these items out on the net and use them or adapt them. But we should also note that these tools, while they are useful, screening does not equal diagnosis. We need specialists, we need experts, clinicians to be able to make a formal diagnosis of whatever the patient or the family members may be experiencing. And as such, Positive scores should trigger appropriate referral to a psychologist, a psychiatrist, a social worker, or depending on what is being indicated. So in describing those tools, especially the quality of life tool, we've talked about some of the typical areas usually assessed in pediatric oncology. And so important among them is the emotional distress. Something that is like a common, or I mean in literature, and that I've also found out in studies, is the fact that children with cancer do not often report high anxiety and high depression, but it does not mean that they do not have concerns. Their parents would often report higher scores on these disorders or symptoms of anxiety or depressive symptoms, right? But it's important to be able to screen them, ask them the specifics to understand exactly what their areas of concern are. And then family functioning and caregiver stress is also very important, right? Because after screening, then you are able to identify where does the stress lie, where can services or what sort of counsel will be needed to give to this individual. Sometimes there are existential crises or spiritual concerns that patients and their family members may have. All of these are what screening for. So these domains guide referrals and tailored interventions across diagnosis, treatment, and survivorship phase. So this is the pediatric psychosocial preventive health model. This model suggests that pediatric cancer should be viewed as an abnormal life event that happens to competent families. And that was why I stated earlier that oftentimes families affected by pediatric cancer, they are resilient, right? They are just regular families like yours and mine. But an adverse life event happens. And this individual also possesses the capacity to adjust and to cope with this stressful life event as time goes on. But oftentimes, they need help. They need support to be able to get to that point of adjustment as fast as possible. So the expected pattern is, and I mean, initially there's that intense distress that patients and their families may experience, and this may reduce over time with peaks at times of acute events, such as recurrence or progression of disease. So the pediatric psychosocial preventative health model is a tiered approach to care that stipulates all families should receive universal care at this base. So at the very beginning, everyone affected with pediatric cancer should receive a basic form of care at the least. Then, as you progress and with screening, we can now know after this basic universal psychosocial psychoeducation provided for all families, family-centered support, screening to identify high-risk group, then from that score, now using the PAT, psychosocial assessment tool, scores of 0 to 0.9 could still remain at that general group where we provide psychoeducation and all of that because they are relatively coping well. When the score gets to 1 or 1.99, these are targeted group where you want to understand what is the distress, how can it be resolved. Sometimes just being able to answer their questions may be able to resolve the issue that the patients have or addressing certain symptoms that the patient may be presenting with. But on that part, that is psychosocial assessment tool, patients who score 2 or more in the assessment would need more. It's indicative of clinical, a clinical level of distress that may need the consultation of behavioral health specialists, maybe a psychiatrist, a psychologist, depending on what the patient is presenting with. Okay. So, pediatric oncology survivorship screening consideration. Now, there are times when patients may have reached remission, no more cancer cells are seen in these patients, but we do not just want to leave them and let them go, right? We need to be able to realize that there are times when there are late effects, either cognitive, emotional, and social. And there's this routine clinic visits that they should have. And there's a need to have a tool that can screen for these issues and also issues related to return to school, school reintegration, and reintegration into the community to understand the challenges they may be experiencing and to help them, cope with these challenges as much as possible. And so this underscores the need for survivor-focused screening tools that helps us understand how these patients are doing, I say maybe post-treatment, after they've reached remission and completed their treatments. So, what are the principles of psychosocial oncology screening? And so for psychosocial oncology screening, we need to be able to answer those basic questions related to who, what, where, how, when. These are important questions to answer, when thinking about psychosocial oncology. And so, for instance, we may want to ask who, in terms of who needs this psychosocial screening? Who should perform the screening, right? We do know that in certain centers, there are shortage of behavioral health specialists that could undertake the task of actually screening the patients and their family members, but we must be able to determine the minimum qualification or the minimum kind of training that this individual or individuals would have to be able to assess these patients for psychosocial distress. And then in terms of who is also, what is the age of the person we are screening? Because there's a need for age-appropriate and developmentally sensitive tools. And that is why the quality of life instruments for pediatric oncology, it's a beautiful tool because it looks at children from across different ages of the developmental stage. And so being able to identify the who of the psychosocial screening is very important. When is also very important, right? I think part of the who is to say, is it a universal screening or is it a targeted screening? Are there specific people we are screening, right? As against, is it a universal screening? Then the when has to do with at what point of the treatment should screening be done? And I'd say that it should be done across the level of care, from diagnosis until survivorship, right? And long-term follow-up, because there's a need for that back and forth in being able to identify what the patient is going through. So there's that initial diagnosis, and then each clinic will then need to determine, because of resource constraints, each clinic will then need to determine at which specific point do we need to screen. Should we screen after each chemo, for instance, or should we screen before and at the end of specific types of treatments? So these are decisions that need to be made with the multidisciplinary team. And then there's a need to think about cultural responsiveness. The screening has to be culturally responsive. I mean, maybe in terms of language and being able to give cognizance to those that should be given cognizance to. So there's that need to respect different religions, cultures, and orientations, acknowledging inequalities and barriers encountered by some children and adolescents when assessing services. So these should be put into consideration when we are assessing children. Then the issue of confidentiality. consent and assent is also very important to consider during screening. We know that the parents need to give consent, right, before screening is done. We must have that verbal consent and where possible, even document that consent. So while children, say less than 18 years, cannot give consent, they can give assent, right? At least they can say, okay. And so if the parents give consent and the child says no, we can't proceed with that screening, right? We only hold them the duty to explain why we need to screen. And that is why using the universal approach is important. And so the universal approach just says that this is our clinic's culture. Every patient that comes to our clinic is just the same way the nurses would take the vitals. So every patient that comes to our clinic would need to go through this distress thermometer, at least at the universal level. Then at the targeted screening level, the patients may then choose to either opt in or opt out because there should be a standard of care. And then there must also be prompt scoring and interpretation of results. Because if results are not scored promptly and interpreted, then we cannot appropriately triage our service use to the areas where they may best benefit from our services. So challenges generally with screening in pediatric oncology is the fact that there are limited resources and limited dedicated psychosocial oncology staff. What we would usually have is people coming and going on consultation basis. But I dare say that every pediatric oncology clinic needs a dedicated psychosocial oncology staff that is assigned. And it shouldn't be one that is changed too frequently, because there's that sense of bonding, that sense of therapeutic alliance and relationship that needs to be built over time with patients, right? So that they can be open enough to talk about their problems without feeling odd about it. And then time constraints in clinical setting is also a huge concern amongst several clinicians. Political will and lack of political will and structure. So if there's no political will that would enact these policies, that will drive these policies to ensure that psychosocial screening is done as and when due, then it will be difficult. There are also cultural barriers and parental resistance. Then tool selection and validation of diverse population is also very important, because we know that even in the cancer setting, there are different, there are children with different types of challenges, right? Those that do not learn fast, maybe one form of learning disability or the other, neurodivergent children, for instance, may also be part of the population we care for in pediatric oncology. And so we do not have enough tools yet to address all of this. And so doing this would demand that sometimes even within our clinics, we know the challenges we encounter, and we could design instruments and validate these instruments for our own setting and the kind of population that we serve. We may choose to translate validated instruments even into the local languages, right? And then oftentimes, even when psychosocial oncology staff go on this on screening, sometimes this screening results are not documented. It is important that they are documented, and especially in clinics where they are now running electronic health records. It should be documented so that doctors that are coming, other healthcare providers, other clinicians seeing these patients are able to see social screening results and know how to act accordingly. Okay, so in conclusion, psychosocial screening is critical for holistic pediatric oncology care, and early identification improves mental health, adherence, and quality of life. Multidisciplinary, ongoing, and developmentally appropriate approach is key. One professional cannot do it all. let's all bring our contributions to the table so that we could have more children surviving pediatric cancer in our settings. Thank you.
Thank you very much, Dr. Elizabeth Akin-Odoye. A virtual applause is going out to you. Thank you so much for the detailed and highly educative webinar. I know many of our participants will have questions for Dr. Akin-Odoye. She'll be joining our distinguished panelists, and then we'll have some discussions, and then we'll open the floor to our participants for engagement. And then so you could ask questions and make your comments and also seek clarification. So it promises to be a very engaging session, as I said earlier. I just want to say this quickly, that this webinar is being videoed. So I would advise or suggest that our videos are appropriate and decent. If you have your video on, make sure that your surroundings and where you are is decent for capturing. Just wanted to say that. So we have here in our midst three distinguished speakers that will be part of our panel with Dr. Akin-Odoye, and I'll just introduce them and ask them to just unmute, to just make sure that you're here with us. So we have Dr. Blessing Oluloye. She's a clinical psychologist and a lecturer at University College at University of Ibadan. You're welcome here. Could you unmute so we can know you're here with us?
Thank you very much, Dr. Sarami. Good evening, everyone.
So thank you.
Please, can you hear me?
Okay. Yes, I can hear you now. Okay, so you're welcome. Also, we have Chief Nursing Officer Folakemi Oyedele at University College Hospital Ibadan, and also a lecturer at the School of Nursing at University College Hospital Ibadan. You're welcome to our miss.
Good evening, Dr. Sarami.
Yeah, no,
Good evening, everyone. I'm happy to be part of this. Thank you so much.
You're welcome. Thank you for joining us this evening. And then we have with us some consultant pediatric oncologist, Dr. Amarachi Abasi. Please could you unmute and so we can acknowledge you.
Good evening, everyone. Thank you for having me.
Thank you so much for being here with us this evening. We're going to have a robust discussion, and thereafter would open it up for our participants so that they can truly gain and learn and also share part of the experiences with us. So Ms. Blessing, are you here with us? Are you online?
Yes, I am. Good evening, everyone.
Yes, you're welcome again. So I'll be taking this session. I'll be moderating with Ms. Blessing Joseph, and we both will be talking with our panelists this evening. So I want to start with Dr. Habasi this evening. So the question will go first to you. From a pediatric oncologist perspective, can you hear me?
Yes.
Okay, so from your own perspective as a pediatric oncologist, what do you think, or why do you think psychosocial screening is as important as a medical assessment for pediatric cancer patients?
Thank you very much, Dr. Poluke. And I want to appreciate what POSON is doing. I think it's been a very enlightening time, the lecture that Dr. Doye gave. It has made my address of your question very easy. And yeah, so for medicine, one of the goals of treatment for all cases is a holistic care. And this cannot be overemphasized for chronic diseases like cancer. Cancer is one case where you see the child, the parent suffer not just physically, they suffer emotionally, psychologically, and in other ramifications. And so it is not just enough to make a diagnosis and go out to treat. Just like Dr. Doyen pointed out when she was having her presentation, that assessment of distress, which has been called the sixth vital sign, must be something that should be assessed at the beginning of care, so that for every problem identified, it will be tackled head on as much as possible as the teams that are caring for the child can. Research has shown that where psychosocial problems are well addressed, that treatment abandonment, poor adherence, missed follow-up, and all the problems that our society is fraught with, that's one of the biggest challenges we have. Treatment abandonment, not just that they present late and then there's treatment abandonment. So with good psychosocial screening, there will be a drastic drop in this, which will lead to improvement in not just morbidity, but mortality in our cancer cases. So psychosocial screening is a very important part of management for cancer patients and can never be underestimated. Thank you very much.
Thank you so much, Dr. Abasi. You picked up my like a follow-up question. So you talked about how important it is. So in your own perspective, how do you feel, at what point should the psychosocial screening go on? Dr. Doyle talked about different aspects. How visible is that for your practice to have a psychosocial screening, a diagnosis? At what point do you think we should have this? At what point do you think is most important, or we just have to make sure that it goes on through the cancer care continuum from diagnosis down to survivorship?
Thank you. So for us in the University Hospital in Ibadan, we have the privilege of having a clinical psychologist, a pediatric psychologist that is attached to the pediatrics department. And oncology unit is the favored unit where they attend the most. And so a lot of time, despite the challenges of shortage of healthcare personnel, I know a lot of time, if we don't see them, that means something is calling their attention somewhere else. But a lot of time they attend ward rounds with us. And this has been very helpful for us to initiate psychosocial screening. So ideally in practice, when you make a diagnosis, you must sit with the patient and discuss that diagnosis extensively as much as you can. So at diagnosis, that must be done. Ideally at presentation, you should assess the patient. At diagnosis, it must be done. And then at every time that a significant change is made in the care of the child, whether the child has relapse, you have to change therapy, you have to go for surgery, the child is responding, there must be a reassessment of how the child, the parents are faring, how they are coping. What do we have to do? How do we have to help them? Are we helping them enough? The treatment we are giving them, is it just improving the child physically and causing problems psychologically, socially for the child and the parents. And so for us, it is not a matter of choice. We make it a mandate that when that diagnosis is done, then there must be a counseling section. That counseling section is multidisciplinary. So it's not just the doctor usually. The oncologist is there, the nurse is there, the clinical psychologist is there, and other persons that accompany us, and the social workers are also there. And so this has come to help us a lot with cancer care. And so it is not a one-off. It is not a one-off interaction. It's the best approach is continuum of care, and it should be done at every point where significant changes or decision is made in the care of the child. Thank you.
Thank you so much for your response. So what I see is that there is definitely no communication gap between the oncology healthcare professionals and your team, because you're the synergy and collaboration and then get the best clinical outcome. So communication gaps are definitely not a problem. Thank you so much for your response. So our next question will be Ms. Blessing, please.
Unmute yourself, Blessing.
I've done that. Thank you. Okay, for the next question, which we are going to the oncology nurse. Please, can you let us know, Nox Folakemi Oyelede, thank you for having you in our midst. And as an oncology nurse, we know that nurses often spend the most time with patients and their families. What early psychosocial warning signs do nurses commonly notice in children and adolescents with cancer care?
Sienna, you're muted.
Oh, sorry about that. Good evening, everyone. Thank you, Dr. Aki Odunye, for that beautiful presentation. It was very insightful. I enjoyed myself. And one of the signs that we noticed during our interactions with the patients or the patient's relatives is we observe for emotional distress. We observe for anxiety, persistent sadness. We also observe and watch out for emotional withdrawal from our patients. We also observe sudden mood swings. Is there any anger outburst after giving them the information on their treatment plans? We also, notice or observe for signs of social withdrawals. We ask their parents, are they interacting well with their peer groups, their siblings at home? Are they interacting well with the parents? Do they observe any withdrawal from daily activities, and so on and so forth? We also ask the patient's relative on, are they having difficulty in concentration at school, at home? Do they show expression of hopelessness when they come to the clinic, when they are at home? Those are the signs and symptoms that we observe. And we also ask the parents about that. Do you notice any of the symptoms? Because as nurses, we do our initial assessments when they come to the clinic, before and after diagnosis. We also assess the patient and the family during treatment plans, when we are changing their treatment plans, when they interact with us, when they have financial constraints, we refer them to the appropriate multidisciplinary healthcare professionals. Thank you very much, ma'am.
Thank you so very much for the great inputs. Okay, having gotten this information, Ma, please, we want to learn from you. How can nurses use these everyday interactions, such as during chemotherapy or ward rounds, to informally screen for psychosocial distress?
Hello, ma.
Yeah, did you get the question?
No, ma, can you repeat the question?
Okay. How can nurses use these everyday interactions, such as during chemotherapy or ward rounds, to informally screen for psychosocial distress?
Yes, usually when patients come for chemotherapy and other treatment plans, we interact with them, we check their vital signs, and as distress thermometer has been introduced as the sixth vital sign, we apply distress thermometer to assess for anxiety before chemotherapy. And afterwards, when they are done, we also use distress thermometer to assess their distress level also. We ask open-ended questions, gentle questions on how they are coping with the side effects of the drugs. We also ask them about any side effects, how they are coping with any side effect from the last treatment plan. We ask them that have they been having, what is their hardest part of the week. We try to interact with them using therapeutic communication to be attentive to them. We listen to their complaints. We observe for changes in their mood through the use of distress thermometer. We compare behaviors before chemotherapy, after chemotherapy. We compare behaviors after a treatment plan. We compare behavior during their visit to the hospital. Is there any difference from the last time that they were in the clinic? Some of them will be very quiet when they come. We ask them, we probe further by asking questions. Then we also use non-verbal clues to observe. We watch for poor eye contact when they come. Is their emotions flat? Are they restless? Are they tearful during this procedure? Are they withdrawing from procedures and all that? Those are the things that we watch out for. And also in adolescents, we observe for body languages that suggest, are they being victimized in school? Are they ashamed? You know, are they angry? Are they disappointed? We observe for so many things using the distress thermometer, and also through interpersonal relationship with the patients. We pick one or two things and we refer to the appropriate sector. Thank you very much.
Okay, thank you so very much for that great input. We'll have another question for you, Ma, on this. What role do families and caregivers play in psychosocial screening, and how can nurses effectively engage parents without increasing their anxiety or guilt?
Okay, Blessing.
Hello, ma. So what we do is we observe for parents' mood when they come. We ask questions about is the patient's appetite fine? We ask about the patient's school engagement, the behavior before and after treatment. We also try as much as possible, because their parents are the child's interpreters. You know, younger children may be having struggles to verbalize their emotions. So caregivers usually help in explaining their fears, if there is any change in pattern, their coping styles. Is there any stress trigger? and so on. Those are what we ask the parents for. We also ask parents that how are they coping. We teach them different coping strategies, that they can use to prevent burnout. We educate the patient's relative or families or care provider on, increasing on what can increase, or what do they think can increase the child's psychosocial distress. As nurses, we also engage patients emotionally. We allow them to interact with us. They tell us their fears. We give them appropriate information at the right time that they need the information. We try as much as possible to ensure that their visits to the clinic is short, is not prolonged, to reduce their stress. Also, we also emphasize on talking to other family members that can provide emotional relief to them. We talk to them about, is there anybody they want us to talk to that we can invite to help them ease their burden. We also talk to them that they can also ask for help. They can ask for help. They should not be ashamed to ask for help. We educate them on so many things, the nutrition of the child. If the child is coming up with a particular behavior, please be patient with your child, because the child might be having different side effects to their treatment plans and so on. So we try as much as possible to engage the family members and also to allay their fears. Thank you very much, Ma.
Thank you so much, CNO, for that detailed explanation. We'd like to engage the clinical psychologist at this time. Dr. Blessing Oluloyo. Can you hear me?
Hello, Ma. Yes, I can hear you, Ma.
Okay, so thank you again for being in our midst. We have some questions. We've listened to a very detailed and excellent presentation from Dr. Aki-Onkoye, but we wanted to dissect it a bit into details. The psychosocial screening, what does it really mean for pediatric oncology? How is it different from the general full psychological assessment you make as a clinical psychologist? And in your practice, which of the validated tools have you found really useful, particularly in our setting as low and middle income countries?
Okay, thank you very much, Dr. Sarimi. And I also want to join others to appreciate Dr. Aki-Ondoye for the great presentation. She actually did a whole lot and made it easier also on my part. So I don't know if you can still hear me.
Yes, we can.
Okay, so for the psychosocial screening is a brief, systematic, early identification process. So when we do psychosocial screening as psycho-oncologists, what we want to do is within 3-5 minutes, we want to be able to detect any symptom of emotional distress maybe in the child, the adolescent, or the caregivers. And when we talk about the caregivers, most time we talk more about the parents, but I would want to also include the siblings because they can also be caregivers. They can be depending on their ages also. So we detect within short period of time, emotional distress, behavioral functioning, social functioning, school disruption, spiritual issues, family distress, and treatment understanding. Within a very short period of time, we try to do this because we cannot just treat the children and leave the psychological domain out of it. Now, what makes this different from psychological assessment is that this screening only flag risk. It opens the door for us to know if there is something happening somewhere, just like we do the breast cancer screening. We want us to know, okay, if there is a lump somewhere. So that is something a psychological screening would do. We want to detect if there is a distress coming up. And then from there, we move it on. If we are able to flag something that we want to explain more, we go into the psychological assessment. Now, what psychological assessment does is that there's a longer period of time used for this. Because for the psychological assessment now, it's not just the paper pencil test. It is not just the observation we want to do. Now we are going in for clinical interview. We are going in for more intense observation. We are bringing other psychological tests to validate and to make diagnosis. So that is the difference I want us to get. For the psychological screening, what we do is just to detect risk. Maybe something is happening. But when it comes into the psychological assessment, we want to make appropriate diagnosis. Now, bringing it down to what we do in our own setting, as psycho-oncologists, okay, in low and middle income country, the distress thermometer has actually been one of the most common and accessible psychological screening, not just for children, even for adult cancer patients. But since we are talking about the children and adolescents here, yes, the distress thermometer, we have the one for children, we have the one for patients, and we also have the face value screening. That is distress thermometer, the face aspect of it. And that is mostly used for children that cannot verbalize their feelings. We make use of their facial expression, their non-verbal cues to actually screen for psychological distress.
Okay. Thank you very much for your explanation. My question, this goes to Dr. Elizabeth. In your own practice, which one have you found most useful? And are there tailored psychosocial screenings for different age groups, particularly children who may not be able to verbalize distress? Dr. Kyondai, did you hear me?
What did you say? Please repeat. Dr. Sarimiye, I didn't hear you. Can you repeat? Please repeat, Dr. Sarimiye. I couldn't hear you.
Yeah, I'm here.
Okay. Okay, I think Dr. Kyondai, are you back?
Yeah, my internet logged me out.
Oh, okay, all right. I was asking a question, but I'll come back to you. Let me just go ask Dr. Abbas. So I wanted to ask this question. How does age, developmental stages for children, do you think can influence the psychosocial need and the screening approach for children? Can you hear me?
It's going up.
Not very well. Please take it again.
Okay, can you hear me now?
Yes.
I said, how does age, developmental stages, and the type of cancer, as a pediatric oncology, do you think will influence the psychosocial need and the screening approach for children versus adolescents?
Okay, thank you for that question. So, age is very important. It's a decider of what to ask and which approach to use, because children cognition is different at different age groups, and so their understanding of their use of communication and understanding of communication is different. Say, for example, you want to talk to a child that is less than 7 years old. He has not started at less than 6, 7. They've not started doing a lot of logical thinking. And so you want to explain to that child, it's just basic terminologies relating to his pain and how it will be relieved, just to calm his anxiety. But for a child that is, say, above 12 years, that is already thinking, has developed good abstract thinking, the communication and discussion to enlighten the child of what you're doing for him presently and then long term. We have a bit more details, because this child can now process this information better, almost like an adult. And so the choice of words, the explanation will be more detailed than you're talking to a child that is, say, 7 to 11 years old. And so age is very important when you want to decide what to use, and which scale and how to go about it. But be that as it may, no child should be excluded in do I say counseling, in psychosocial screening, because for all of them, they go through some form of distress. They all go through distress, and they show it differently depending on their age. So you said age and development and type of cancer. Yes, a child that has osteosarcoma and a child that has Wilms tumor, the change to their body image will not be the same.
Yes.
And so you need to explain to this child why it is necessary that he loses that limb, and all the problems that will come with losing the limb, and the curative effect losing the limb we have, the adjustment to life the child will make for losing the limb, sports wise and other activity, of course, body image wise and all that. You have to talk to the child so that the child will be able to handle what comes out from stigmatization, how the child looks at himself or herself following care. If not, the child will revolt. It may not, some children may not come out completely to say it or to act it, but internally it is almost as bad as them showing it. It's even those that keep it in that at times, most times, have this suicidal ideation tendencies and tend to carry it out or refuse treatment and all that. So a child with nephroblastoma, yes, we have surgery, but body image may not really be affected so much. Then for adolescents, you see that loss of hair that comes with the side effect of loss of hair that comes with therapy, especially for the females. It's a lot. And you have to try and assess them, talk to them, see how they are managing, and teach them how to carry on, hold on, live life, and still fit in to their age appropriate activity without feeling that the cancer has shut them out, the therapy has shut them out, has shortchanged their life. They can't be a teenager again. They can't relate to their peers. We see children withdrawing, going into depression, and different problems just because of the problems they face from either directly from the cancer themselves or from the therapy. So yes, age appropriate conversation, age appropriate screening, and depending on the kind of cancer, yes, the screening will be very different, and what you'll be delivering to the child will be very different. Thank you.
Thank you so much, Dr. Abasi. I would want to open the floor for our participants to interact and engage. I just want to add this question, the vision and the mission. Once again, I acknowledge and appreciate the International Psycho-Oncology Society President, Matriarch and our mother, Professor Chioma Azuzu, that is here in our midst. She's the founder of POSON, and she's been in the forefront of pushing the mission and the vision of psycho-oncology, not just in Nigeria, in Africa, and globally also. So you have an established center, Dr. Abasi, and one of the things that has helped, I'm sure, has to do with a lot of political will and all that. So for centers who really want to incorporate psycho-oncological services into MDTs, because you've seen the importance of why we need a pediatric psycho-oncologist in the treatment and the holistic care of our patients, children living with cancer. What are some, just in a few words, some lessons or experiences that you think other centers can learn, that who want to also imbibe or start this kind of MDT approach towards taking care of patients, particularly incorporating psychological services in the management of children living with cancer?
Sorry, I didn't get what the MDT was, please.
No, I was just saying that what experience that since you have an established MDT, the center you work, and you also have an established psycho-oncological services provided for this children, that for centers who are just about to start and trying to incorporate this, what do you think, just in few words, what do you think they need to put in place to make sure this is incorporated in the management of children living with cancer, drawing from your own established center, from your own experience?
Okay, thank you for the question. So from our experience in the University College Hospital, the Pediatric Oncologist, so we have the opportunity of having clinical psychologists, we have medical social workers, we have child psychiatrists, we have trained nurses, although we don't have in pediatrics, but we have some trained oncology nurses, and we have the palliative team at our disposal. And so for centers that are looking at harnessing the advantages of psychosocial psychosocial therapy of optimizing psychosocial therapy in the management of their patient, I would say that they should think of getting the services of these persons. I would also say that just like in our center, when we go for rounds, we go with it's a multidisciplinary round, usually. And so we go with our nurses, oncology nurses or not, the clinical psychologists, they come with us when they're available most times. And the social workers are at our disposal. We have social workers that are dispatched to pediatrics. And so when we have problems, issues, it's not coming from one person's perspective. You see, the power of somebody else beside the physician addressing this problem is huge. And a lot of time, it helps to calm the patient down. It helps to open up avenues for us to interact, discuss, and see problems. Because if it's just the physician talking, it may be that it may be looking like it's just we are just giving them book stuff. You understand?
Yes, yeah. Okay. Hello. Okay. I think we
But
will
when
lost your voice. Go on.
we have the time with this patient, is a lot at every. Can you hear me?
Yes,
Can you
ma'am.
hear me?
Okay, we lost you for a bit, but we can hear you now.
Yes. So they need to incorporate multidisciplinary approach. That's the teamwork should be multidisciplinary at every contact with the patient as much as possible. So
Okay.
this will bring out the best for every visit. I think the use of the screening tool, the distress thermometers too, it doesn't take so long. I see our nurses when you come in for admission, they sit with the caregivers. It may not be immediate, but at least within 24 hours, they sit with the caregivers and take all these questions. What do you do? How do you feel? You know, they go and these are questions that also helps to assess beyond just the diagnosis, other aspects of the life of the child and the family that helps in the care. And then from other interactions that the nurses and we have off the ward round period. I am proud to say that a lot of times our patients open up to us. They tell us even private things, private problems that they face. And this is because we are not just talking, we're not just telling you, like, we don't disconnect from them. We go beyond just telling you that this is what you need to do, to actively trying to help you. It's task skill, physically, emotionally, and psychologically. But that is the UCH experience. We go beyond just telling this is what you have to do. We actively get involved in helping you try to get those things done. And this has helped a lot of our patients this has helped us to gain trust for our patients and has helped us to deliver. Of course, we have constraints, a lot of constraints, but it has helped us to deliver good services with the limited resources that we have. So I think if people can learn that, try not to be limited. Don't say this person doesn't have money. What can you do? Try and see. We have people that come, they don't have money. By the time we engage medical social workers, we try to talk to people, money will come. It wasn't like we
Okay.
expect it. And then we start the care. So it's a lot of work. It's
Yes.
a lot of sacrifice, but when you do it, it's very rewarding. Thank you.
Thank you so thank you very, very much. Our time is limited. Thank you so much, our panelist, Dr. Blessing Luloye, CNO, Falakemi Oyedele, Dr. Amaricho Basi, Dr. Elizabeth Akin-Odoye, our guest speaker. I will want to leave the floor to our participants to ask some questions so we can interact. So you could just raise up your hands and then we'll tell you to unmute and then we can talk. In addition to what Dr. Abasi, you said, you talked about, I think also political will from the management of the hospital to goes a very long way, that they buy into this MDT, holistic approach in terms of taking care of pediatric oncology. So political will also from the management, from your department to from the physicians and the oncologists in your department to also, I think, has helped a lot to make sure that this goes on in terms of incorporating psycho-oncological services for the patients diagnosed with cancer. Okay, so Psych Adewale Aisha Abimbola can unmute and ask the questions, please. And other participants, if you want to contribute, make comments, raise your hands and I'll call out your name and they can unmute and ask the questions. Aisha Abimbola, your hands are raised, unmute and ask the questions.
Yeah, good evening, everyone. Thank you so much for this insightful webinar. I learned a lot from it. If there is a part I did not get, which I just want to clarify, is at what age do signs of cancer elicit in children and adolescents? And so far, with statistics, what is the common cancer in adolescents now? So that when we are preaching against screening, we are also letting them know that this is the commonest form of cancer, so that they too can know how to stay off it. I understand that there is really no one cause for cancer, but at what age do we see signs that this child has cancer? Thank you.
Thank you so much for your question. That question will go to Dr. Abasi. She's the pediatric oncologist. She'll be able to answer that. So Dr. Abasi, please take note of that question, please. And at what age can we begin to see signs and symptoms for pediatric cancer? Mr. Igbe Dorothy, you'll have your hands raised. Please unmute and ask your questions.
Okay. I want to thank the presenter, Dr. Elizabeth Akin, for that wonderful presentation. Yeah, I want to say clear, sir. You said in your presentation that when the relatives are sent, and but the patients do not accept or do not allow you to screen, you don't. Or when they say no, you don't go on with screening. So I just want, maybe I didn't get you very well anyway, but then I want to ask, what else can we do in order to ensure that the screening is done, even when the patient says no?
Thank you so much for your question, Dr. Respond to that.
Yeah.
More questions, comments, clarifications? When you ask your questions, you can let down your hands. Dorothy, you can put down your hands. You've asked your questions. Are there more questions for Dr. Akin-Odoyin and our distinguished panelists? Okay, so maybe meanwhile, Prof.
I don't have a question, but I want to make a contribution at the end of the questions.
Okay, ma'am. Yes, ma'am, of course. Yes, ma'am. Okay, Dr. Abbas, maybe you could go on and answer Abimbala's question, and then Dr. Akin-Odoyin, you would afterwards answer Dorothy's question. Yes, please. And I also have questions for you.
So, Aisha, there is actually no age that cancer cannot occur. You know, that's one myth that I've come to with practice. You come to see a lot of people like they are surprised that a child can have cancer. What did this child do? This child is not smoking, is not drinking. How come? But you know, for pediatric cancers, the etiology is idiopathic, meaning the cause is not known for a lot of them. A lot of them have to do with spontaneous mutation and not necessarily inherited mutation. Of course, there are risk factors like exposure to some chemicals, radiation, and all that, or maybe the mother was exposed, and yes, genetic inheritance and all that of some of those mutations. So there is what we talk about in childhood cancer is which some cancers are common in some age groups. So like 2 to 3, you say retinal, nephro, neuro, like that. So ages, which ages have more a particular kind of cancer more, but I've seen cancer in children that are like 1 month, 2 months, 3 months, and so it can happen at any time, and it's no fault of the child, it's no fault of the parents. Then the commonest cancer in adolescents is Hodgkin's lymphoma. And usually it would appear as a mass. The common areas that the swellings occur is around the neck. So usually the nodes areas around the neck, that's the one you can see around the neck area. Those are the common sites of the swelling. Maybe the armpit, the groin. But if you do X-ray, another common site is mediastinal masses. So Hodgkin's lymphoma is the commonest adolescent cancer that we come to see in practice. And one of the advice we give people when we go out to create awareness is, when you have a swelling, it's not going away. Please don't try to treat it. Hodgkin's lymphoma is indolent, meaning it's slow growing. Unlike bucket is fast growing. You see people, because it's slow growing, it's not going away. Please go and seek expert care. Don't go to just a regular hospital. Go and see a specialist. Once you have a swelling, it's not painful. Sometimes it's painful if it's infected or a structure around it. But most times it's not painful. And it's just there, either slowly growing or not going away. Please see a doctor and seek expert care. Thank you.
Thank you so much for your explanation. I believe, Aisha, that has been I've seen your response. Thank you so much. So, Dr. Akindoye, in addition to the questions that we asked, just want to ask that in your own practice in pediatric psycho-oncology, which of the validated tools have you found most useful? And that lastly, that what key message should every clinician remember about psychosocial screening for children and adolescents with cancer?
Okay, thank you. And so I think first and foremost, with regards to Dr. Dorothy's question on whether if patients or their family caregivers say we don't want to assess for screening, then what do we do? I think the best place to start is first educate them about what you want to do, like any other kind of clinical procedure, right? Before you take a draw from a child or from an adult, a blood draw, you want to explain to the child, I'm going to be doing this or that, it's going to prick or whatever. The same way, when we want to assess for distress, we want to explain to the patient or the service user from the beginning, this is something we do here in this clinic for everyone. So we normalize it. When you normalize it, you will find many more patients agreeing to doing it. And even when a patient does not want to be screened, you want to understand why. I say if we are able to address their why, then it's possible to be able to screen. And so sometimes it may be, I'm not just in the right mood now. Could you come at another time? So eventually the screening may still get done, but it may not be at the very time that the clinician wants to have it done. So that's one with regards to Dr. Dorothy's question. And then the other with regards to which instrument have I found most useful? The way I would answer that question is that no particular instrument, I can't say a particular instrument is the best because there's always a form of gap. And so to determine which instrument you want to use, then you must have your question. What question do you want to answer? What have you observed that you think you want to objectively screen for, hearing from the patient's mouth? As if it's anxiety, or is it depression, or is it body image issues? So you already have your intuition that this individual is having this thing, but you want to reconfirm with self-report instruments or a proxy instrument, then you scout for the particular instrument that would address that situation. Otherwise, we just use the distress thermometer. And so the distress thermometer will provide a pointer, and you may now do a second level screening, then before proper assessment, because there are a myriad of screening instruments that are available out there. But the important thing to answer is, what am I looking for? And what you are looking for will then determine what to do. And so with regards to a closing message for clinicians is the fact that we should put the patient at the center of our care, right? We don't want to claim a patient as our own. Whether the patient is in the mental health department or in the oncology department or in whichever department that patient is in the hospital, we should be after holistic care. And holistic care means that the different domains of care, the different domains of psychosocial needs are appropriately screened and addressed once the screening results has determined what the problem is. And so we should work as one, just like the different parts of the body. None can take superiority over the other. So the same way in the healthcare system, and especially in the oncology space, we should work as different parts of a body, working towards a comprehensive care of the patient and their family with cancer. Thank you.
Thank you so much, Dr. Odoye. I thought that would have been the last question before Prof. Choma Azuzu comes up. I saw a message, Toluwanimi, you have a question. Could you quickly unmute and ask a question? We don't want anybody to go. Okay, and then also, I'm just seeing this now, Joyce Tawashetu. Okay, Toluwanimi, quickly ask a question, please. Yes, good evening. Please go
Can you
ahead.
hear me, ma? Good evening, everyone.
Good evening.
Good evening.
Hello?
You can go ahead,
Okay,
please.
ma. So I just wanted to ask that how can we help patients to better adhere to their chemotherapy sessions or their medications as the case may be, so that they can their quality of life can be improved and there will be better outcomes. So better adherence, how can there be better adherence on the part of the patient
Okay,
from the clinical view?
Let me answer that question. In terms of adherence to chemotherapy, first and foremost, you want to understand what are the challenges these patients are facing. Is there financial toxicity? Can they afford the chemotherapy? Are there side effects that they are trying to avoid? So if we are able to answer these two questions, if there's financial toxicity, do we have resources for which they can seek help, financial help? Are there places where they could get support for medication? All of this will go a long way in helping us determine, how they can get this help. And if there are side effects that need to be addressed, if those side effects are properly addressed, then they are likely to take their chemo. Then in pediatric setting, there's also the need to put the parents at the center, because the child will not get up and come to the hospital, right? And so that's where navigators also come very handy, right? In putting in reminder calls and things like that. And then within the hospital, we as the healthcare providers must also make their hospital experience amiable, must make it good for them, right? Such that they are encouraged to come. I think those little things could help with chemo adherence.
Thank you, ma'am.
Thank you very much for your response. Dr. Tawashe, please go ahead, unmute.
Okay, thank you so much, Dr. Sarimiye, for the chance to speak. I want to quickly say well done to Dr. Akin-Odoye and every other person on the program. And just what I thought about bringing to our notice is that pediatric oncology is actually not it should be a specialized, aspect of oncology in most hospitals, most tertiary hospitals in Nigeria. But you discover that this pediatric oncology may not be found in some tertiary hospitals around Nigeria. So what would the advice be for clinicians who are practicing in these hospitals where they do not have specialized, pediatric oncology, how do they attend to suspicious, cases for this kind of cancers? Thank you.
Okay. But when you mean the pediatric oncology, not pediatric psycho-oncology, right? So maybe Dr. Abasi should answer that. I think she addressed part of it in the previous question. Dr. Abasi, could you
yes. So for
share some insights?
For centers that we have pediatric oncologists, of course, but for centers that don't have pediatric oncologists, what I have heard and what I know people do is the pediatricians work with the adult oncologist. That is what is done. So they work with the adult oncologist and they try to make provisions, adjustments to take and manage pediatric patients with cancer. Some of them, however, if that is not possible, refer their patients to other places where they can get pediatric oncology specialists care. If there are centers that are interested in developing their pediatric oncology specialty, it is something, of course, that they have to be intentional about. The first question you asked me, not the first question, the other question, I think it was the last, why I didn't talk about government, the management will is for you to already start thinking about that means you have a willingness to engage in it. Now, the other requirement, finances, space, trained personnel, and then things that your willingness first can help you to push for. So when the management and the team involved see that they really need to attend to their pediatric patients with cancer themselves, and not because it's a lot of stress when you have to send, but even within the hospital, when you have to call other people to come and help you with the care of your patient, is a lot of challenges, delays, not to talk of when you have to send the patient outside. So if they are willing and they are intentional about it, of course, the other things, finances, capacity training and all that will fall into place. Thank you.
Thank you so much. So a lot of advocacy and political will also goes a long way. Before we close, I would like us to welcome Professor Chioma Azuzu and hear words of wisdom. Prof. Ma, please unmute.
Good evening, everyone. Good evening, Dr. Saramiye, and thank you for giving me this opportunity to make a few remarks. I wish to use this opportunity to congratulate Dr. Akeodonye and all the panelists. Dr. Basi, well done, and Dr. Ayodele and Dr. Oluloya. Thank you so much for your presentations. It was quite an educative webinar. And having said that, we have established during this webinar the need for psychosocial care in the pediatric cancer care. And so, what do we now need to do? Because I think time has come now when we cannot doing this, we must do something to make sure that the policymakers recognize what we're talking about. Having a holistic care is very, very germane, very important and necessary. But how do we implement it in our environment? I think political will in the institutions and also advocacy with the government, with the Cancer Control Agency, with all the relevant agencies that will make this thing possible. To educate all the oncology care practitioners to be able to do certain things. And now the behavioral psychologists, the psycho-oncologists, the counseling and clinical psychologists, to be able to give details, therapies that are germane in the enhancement of the quality of life of the patient. And so that in line with the 2026 World Cancer Day, united and unique, all of us doing the thing in a specialized, unique way of giving this kind of therapy. I think that is what we are looking forward to. And how we can get there, I think all hands will be on deck for us to be to do this and to be able to achieve it, not just in our center, but in other centers, just like Dr. Tewase asked, that don't have relevant key people to be able to give this kind of care. So once again, I say congratulations to all. Congratulations to POSON, and congratulations to the organizers of this webinar. Thank you.
Thank you so much, Prof. Ma. Thank you so much, ma'am. Your passion is always palpable whenever you speak to us, and we're very privileged and fortunate to have you in our midst again this evening. Thank you, ma'am. So thank you so much, dear participants, for staying with us this far. This webinar has been organized by Psycho-Oncology Society of Nigeria. I want to thank our guest speaker, who is also our president, Dr. Akin Odoye, for the insightful and very highly educative webinar lecture that she gave. I also want to thank our distinguished panelist, Dr. Abasi, a consultant pediatric oncologist at the University College Hospital Ibadan. Also, Dr. Blessed Oluloyo, a lecturer and at University of Ibadan, clinical psycho-oncologist. And also want to thank Chief Nursing Officer Falakemi Yedele, lecturer also, and an oncology nurse at University College Hospital Ibadan. Thank you so much, all our participants. Your engagement made it stimulating and made an excellent webinar this evening. So thank you so much, everyone, for coming. And then this is our first webinar this year, and then we plan to have about 3 more webinars in the year. And our communication will be open to keep you informed as it comes. So thank you, and have a lovely evening. Before we go, can we put on our video so we could just have a group photograph? Can we just quickly do that? Where your eye, your portrait. Blessing, could